Here's the information on CMEs. If you have any questions, please reach out to Rana. I'm sure she'd be happy to answer those for you. I or the other members of the Hub team do not have any financial arrangement related to the content of what we're going to talk about today, so I have nothing to disclose. The topic today is to talk about stages of change and the spirit of motivational interviewing. So I'm hoping to cover the concepts, sort of the core concepts related to the trans-theoretical model of change, or what's referred to as the stages of change model, so that you can start to think about how to apply these concepts in your assessment and treatment and working with individuals with substance use disorder. And then talk a little bit about what motivational interviewing is, and how it's related to how you work with the population that you're serving. And then wrap up with some guiding principles that are part of the core foundation of MI, which is the spirit of MI. So that hopefully you'll leave today with an understanding of how to apply the stages of change to how you assess and think about working with these patients, and then how you can apply some of those core components of the spirit of motivational interviewing, even if you don't have the other techniques or skills related to it, so that can be embedded in how you work with your patients, regardless of your role with them. So starting with stages of change. And feel free to interrupt me or chat in if you have questions at any point. I'll try to get to them as we go. And then hopefully there'll just be a few minutes for questions at the end, but I apologize if I forgot to mention that. You can always interrupt if you have a question. Why do you need to know about the stages of change? Well, this is it's called the trans-theoretical model, or referred to as the stages of change model. This is an evidence-based model of how to match treatment for what patients actually need. So it's a way of determining where a person is at in terms of where they are in the process of making healthy changes in their life, and to match your interventions to that stage. So that way you're not trying to give them something that they're not ready for, or they don't actually need. This is not part of motivational interviewing. The stages of change model is a standalone model. It was developed by different researchers, but it's often utilized hand in hand with MI. And so that's why we've combined them today in this talk, and why you often see them go together, because it's sort of at the front end. This helps us to determine where a patient might be at, and then if motivational interviewing fits, to align it with the motivational interviewing techniques. So this is the stage model in a visual representation. And I like this because it doesn't show this in a linear way. And this is a much more accurate representation of how patients actually move through these stages. They don't always start at the beginning, which is pre-contemplation, the bubble at the top. They don't always start there, and they don't always move exactly in this order. But these are some ways of being able to classify where might my patient be falling. And the other thing to think about, and why I like this visual, is that this is a cycle of how people move through making healthy changes in their life, or really going from one habit to adopting a new habit. And if we're trying to change our diet, if we're trying to increase exercise, we're trying to stop smoking, in any of those things that we may be doing with or without substance use, we're going to go through this same process. So this stage of change model is how human beings move from a place where they're not making the healthiest choices for them, to a place where they're actually starting to make those healthy choices and then maintaining those healthy choices. And you can see that part of this cycle includes relapse. So falling back into those old patterns of behavior is a expected part of this this process. And it's important to understand this, to explain it to patients, so that they don't feel like if they do have a slip, regardless of what behaviors they're trying to change, if they do have a slip, that they're not starting over from ground zero. Then in fact, it's really like an upward spiral, which means that they learn every time they re-engage with this cycle. And so sometimes they can go into a relapse and then skip pre-contemplation and contemplation and go right back into action. So they don't necessarily have to go through each one of these every single time. So it kind of removes that that difficulty and frustration that patients might experience if they do have a repeat of those old behaviors. Just like any one of us that maybe has tried to diet at some point in our history, you may be able to sustain that healthy eating change or exercise routine for a period of time, and then slip back into an old pattern of behavior. Well, when you're ready to get back on track, you may not necessarily have to start at pre-contemplation where you have no intention to change. You might actually jump right back into preparation or action. And so that same thing is happening for patients with substance use disorder. So what are we looking for to determine? Well, there are some assessments out there. The Socrates is one assessment that's public domain that can be given to patients as self-report, or you can administer it to them, and it will identify their stage of change. But the research is pretty clear that if we just understand what we're looking for, as clinicians, we can identify what stage someone is in fairly accurately. So with pre-contemplation, what we're seeing when we're discussing with the patient is that they're not really considering change in the foreseeable future. So they're giving you a lot of what's called sustained talk. So they're giving you a lot of reasons why they should continue what they're doing, why they don't want to make any particular changes in their routine or in their behavior. And so we can identify that pretty clearly as pre-contemplation. Contemplation is where you start to hear patients actually talking about change, and not something that is coming from their loved ones or is just repeating back, what they've heard you say, but you're actually hearing them say, yes, I definitely want to stop drinking as much as I am, or I want to stop using, I really want to quit this habit, like that type of language. Then we know that they're in contemplation. Preparation is where they're actually taking steps to plan in that immediate future. So they're talking about, okay, next week I'm going to do X, or even next month this would be my plan. So it's that plan on in the immediate future when they're going to start to move into the action phase. Action is where they've begun making that meaningful change. So they come in to that appointment and they say, hey, I only used 3 times last week. Now they're in action, right? They were actually implemented the meaningful change. And then maintenance is where they are just maintaining that new habit. So where they're able to prolong the amount of time that they're able to stay with that new behavioral pattern. So why is this important? It's because the stage of change dictates the types of interventions that we're going to use. So when you're working with a patient in pre-contemplation, and these are typically the hardest patients to work with, because they're oftentimes not well engaged, they're experiencing a lot of internalized stigma or distrust in their providers or the system as a whole. They're not at a place where they're really ready to talk about planning and implementing specific healthy behaviors, right? So really shifting into talking about change. So what we want to focus on once you've identified, okay, my patient's in pre-contemplation, I need to really build that rapport, that alliance, and that trust to create a safe space where they can feel unconditionally accepted for exactly where they are, that, hey, this is where they are right now. And that this is a safe space or a safe relationship for them to be that without judgment, and to use techniques like a decisional balance, which is just a fancy term for a pros and cons list. So really introducing a little bit of cognitive dissonance around, okay, this is what you're doing right now, and this is what it's doing for you. And if you were to change doing some of that, what would that do for you? This is what you're doing right now and how it's not helping you. If you were to change some of that, how would that actually help you or benefit you? And so having them sort of weigh those things out and introducing a little bit of what's called ambivalence, which I'm going to talk about later, is what you can start to do in pre-contemplation. Contemplation, when patients are here, they're actually ready and wanting to make a change. That's where motivational interviewing, or MI, really shines. So this is where you would use an MI technique. So it's a misnomer. People think somebody's, they're in pre-contemplation, they're not motivated, so let's use motivational interviewing. That's actually not true. Where motivational interviewing is not the right intervention match for people that are in pre-contemplation. We want to wait until there's at least some ambivalence. There's some part of them that wants to make that change before motivational interviewing is going to have an effect. I'm going to talk a lot more about that here in a second. Preparation, where a patient is actually planning, they're in the active process of change. All they need from us is to support that process and help them make reasonable, achievable plans. So just having conversations about SMART goals. You don't need to worry about applying MI anymore. When somebody's hit preparation, they're already in the process of taking those steps, and they might just need a little bit of clarification and support to really help choose a plan forward that's going to be reasonable and helpful. Once somebody hits action, then all we're doing is reinforcing their self-efficacy and continuing to bolster their confidence that they can do this. So that's where relapse prevention really starts to kick in, and applying relapse prevention skills is most helpful. And then maintenance is the same thing. We're just now extending it for a longer period of time. We're helping people to really feel engaged and confident that they do have the skills to do this. They can manage difficult situations, high-risk situations, urges, triggers, all of those things. They have the skills to manage that for the long term, for their long-term recovery goals. So in a little more detail, and I'm going to move through this kind of quick, pre-contemplation, they're just not ready to do anything about the problem, and they're not vocalizing any of that change language. So your goal is to just gently bring some awareness to the problem. It's likely already there, but we need to do it in a way that really conveys non-judgment, because as soon as we start to judge the behaviors that they're engaging in, you're going to get resistance. And so you really just want to be like, okay, this is where you are. Oh, and that's interesting. That sounds really hard and really difficult that you're dealing with that. So just starting to bring awareness to that problem and really working to listen to their concerns, reflect that back, elicit information, even about like, well, what is going well, or how are you handling that? And then communicate that unconditional positive regard, empathy, and acceptance. That's really, really important to building that rapport and that relationship. Once somebody's in contemplation, that's when they're willing to talk about it. And so our goals here are to really keep them talking about change and start to bolster how they're working with that change talk. And that's why MI really shines with people in contemplation, because we're working to develop discrepancy, really reflect that ambivalence, address any discord that might be there. And a quick technique that you can apply when you're working with someone in contemplation is they're talking about, yes, I really would like to change this, but I can't because of X, Y, and Z. Work to shift that but to an and say, yes, you really want to change this, and you're worried that might be really hard, right? So you're allowing for a space to exist in their mind mentally, that it isn't black and white, that it isn't either or, that they can have that discord present and still move towards the goals that they want. So really shifting that language from a but to an and then again, starting the process of supporting their self-efficacy. So recognizing that they have been successful in the past, that they have skills, they have agency that they can tap into. When someone's in action, again, our goals are really just to encourage progress, reduce barriers, and hopefully help them to not bite off more than they can chew. So really saying, okay, what are your plans for this next week? And making sure that that's achievable, because we want them to be successful. So just a couple words about relapse. This is likely to happen. This is really the rule instead of the exception. And so it's okay to talk to patients about it before it happens, because we're preparing them to work against the abstinence violation effect, which is the psychological phenomena that occurs when somebody doesn't meet their goal and they slip back into old behaviors. They say, why does it matter? Who cares? I'm just going to go back to those old behaviors. So we want them to recognize it's not a sign of failure. It's just an opportunity to learn. It's a part of a chronic illness. Everybody slips back into those old patterns, and every time they get back into the cycle, just go right back into action, go right back into preparation, right? Get back on the horse, that saying. So you want to help them avoid being discouraged and help them re-engage in that change process. Okay, so that's the stages of change. So let's talk about the spirit of MI and why that's important. So people are generally better persuaded by the reasons which they have themselves discovered than by those which have come to the mind of others. And that is so powerfully true. If you think about any change you've made in your life, how effective was it when people told you you should do it, you need to do it, you have to do it? probably not that effective, versus when you had your reasons, your motivations, your mind was set and you were ready, then it was actually an achievable, sustainable change. And that's what we're talking about with motivational interviewing. It's not a therapeutic technique as much as it really is just an effective method for talking with people about change. So you can use MI for any kind of health change. It doesn't have to just be around substance use. It's considered collaborative, person-centered, and a way of guiding instead of directing. So you're really trying to elicit their strengths, their motivations, and help them connect with that and capitalize on that. You're not giving them anything, you're just eliciting what's already there. And it's a really helpful way when people are in contemplation to help them move through that ambivalence. It's a different approach in the sense that it's really collaborative and conversational, and not just a collection of techniques. So you can use the spirit of MI even if you haven't really been trained in it, if you really understand it's about meeting people where they're at and trying to elicit what they already have in them, rather than coming to them from a deficit perspective, assuming that they don't have something and I need to give it to them. So it really works with the patient rather than at them. And again, it can be used for a wide range of health risk behaviors. I'm not going to go through the research, but you have the slides. It is extremely research-based. It has tons and tons and tons of studies that have been done on it and shown it to be very effective model for working with people on any kind of health behavior change. So the components start with the spirit. That's the foundation. So if you're doing nothing but applying the spirit, then you're probably going to have more effective collaborative conversations with people. Then there are some specific principles, processes, and skills and techniques that are part of MI that you would need to go on to get additional, more intensive training to learn. But what we're going to talk about today is how do you just apply the spirit, right, without any training. So the foundational aspect of appreciating and applying the spirit is appreciating ambivalence. So what does that mean? Ambivalence just means I'm of two minds. And anytime somebody is really contemplating, they're in a contemplative state, contemplating change, they feel two ways about it. So part of them wants to make that change, and part of them doesn't want to make that change. They like some of the things they're getting from it, or they're scared to do it, or they lack confidence in their ability to be successful. So that's multiple minds that can sometimes be competing. So when we're working with somebody in contemplation, I would encourage you to move away from thinking about them as being unmotivated or lacking motivation, but what they really have is just ambivalence. And that's an awesome thing because we can work with that. If somebody has one of their minds is I would like to make this change, then that's what we can capitalize on. And recognize that being in a state of ambivalence is a normative part of any change process. So if you've ever contemplated making and I go back to sort of the diet example, because most of us have tried that at some point in our adult lives. If you've ever tried to make a change to your diet, it's probably normal to have one part of you that's really motivated to do it and another part of you that's kind of like, yeah, but I'm going to miss donuts, or am I really going to have to go without eating pizza the rest of my life, right? So it's normal to have those two minds present. What we want to do when we're embracing the spirit of when we're embracing and appreciating ambivalence is to avoid the communication trap. And so that's where we want to avoid arguing one side, because what's going to happen is they are going to automatically defend the other. So if they had a part of their mind that wanted to make the change and we start arguing for that change, they're going to start arguing for why they shouldn't. They're going to maintain the status quo, and that's actually going to decrease the likelihood that they're going to be successful. That's called the writing reflex. And so that's the main thing that we're trying to not engage with when we're using the spirit of MI. It's that natural inclination that we have as helping professionals to make it better, to fix it, to solve the problem. Why is this dangerous? Is because just like that quote from 1660, that if we're telling them how to do it, why they should do it, without really having them talk through why for themselves, then it's going to create that resistance and they're going to move away from us. So what happens, why we engage with this is as providers, we've learned that if somebody isn't making a change, it's because they don't see it as a problem. They don't know that it's a problem. They don't know how to fix it, or they just don't care. And so we engage with that writing reflex because we're like, okay, we need to increase their insight. They need to be more aware that this is a problem. We need to increase their knowledge. They need to just know more about what it's doing to their body, to their mind, why it's a problem. And we need to give them skills so that they can actually do something about it. Now, skills are important in substance use disorder recovery in terms of the relapse prevention piece. But as you saw in the stages of change, you're not going to really focus on that until somebody enters action. So that's important when you're working in contemplation and you're dealing with appreciating ambivalence, that you don't engage with giving them skills because they're not ready. That's not what they need right now. What they need is to increase that change talk, increase that motivation, and have a primary mind where change is focused. Because when we hit them with the writing reflex, we try to give them insight, knowledge, or skills. We're going to butt right up against that ambivalence. And what's going to happen? They're going to fight us all the way, right? So sometimes we see patients will make a change briefly just to satisfy us or other family members, but then they go right back into what they were doing before. They may listen politely, but then just leave our office and go and do whatever they were doing before. They may actually push against us. And so if you start arguing with the patient, you know you've butted up against their ambivalence. And at the end of the day, no one benefits. And we typically tend to blame the patients and say, well, they're just not ready. They're just not motivated. And it could be that we were trying to do that while they were in pre-contemplation, or it could be that we were engaging in the writing reflex while they were in contemplation and it wasn't helping them. So what do we need to do instead? Follow the rule. So number one, resist the writing reflex. Number two, understand your patient's motivations and spend some time to draw that out, because again, it's what they have inside them already. What is their why? What is the part of their mind that wants to make the change? Really listen, actively listen, reflect back. Even if you're just parroting back, if they feel understood, if they feel listened to, that goes a long way to moving them forward. And then seek ways to empower them to make the change rather than giving them something. Help them get it for themselves. And what are some ways that we can do that? Well, part of the spirit is moving through the ACE: acceptance, collaboration, and evocation. So what does that mean? With acceptance, what we're doing is we're communicating absolute worth, that unconditional positive regard that is absent of judgment, that includes respect and trust no matter where they are. And this amazing thing happens. Bill Miller, who was one of the developers of MI, he said that time and time again, they would research that if nothing else was provided to the patient except unconditional positive regard and acceptance, if that was it, that was all they were given, that alone would facilitate healthy change. Because this amazing thing happens psychologically with humans when they don't feel judged, when they feel like there is space for them to explore their own ambivalence, they will make the healthier choice for themselves. So recognizing that acceptance frees them up to make change rather than being, I think in our mindset, sometimes we fall into, oh, that's being permissive or that's supporting their continued unhealthy behaviors. But all it's doing is saying, I accept you for exactly who you are, where you are right now. And I'm gonna sit here with you and creating that space that frees them to make the change. In that space, we also want to do a couple of things. We want to work to express accurate empathy, which is really using those reflective statements to say, this is what I'm hearing you say. And it's reflecting back the meaning and the values as to why they want to make this change. And then empowerment, right? That autonomy support. So acknowledging that they have the freedom to make that choice. If they choose to use today, that's their choice. And they know the consequences. If they choose to not use today, that's also their choice, right? So recognizing that they have that autonomy and then affirming their strengths and their efforts, no matter how small. So when we're engaged with acceptance, we are really affirming their right, their capacity to make informed decisions and choice and honoring them regardless of their use, versus having an authoritative approach, which is where they tell them what to do or what they should do, and assuming that they need to be told or instructed. Using collaboration, that's where we're actually, it's considered dancing rather than wrestling. So we're exploring rather than persuading. And this is really a part of that process. So with collaboration, we're honoring that they are the expert in their life. that their perspective is the most valuable, versus that they're required to adopt our perspective as what needs to happen, right? So again, that kind of unconditional acceptance. You're the expert on your life. So if you're making these choices, that's absolutely your call. And here are other options, right? So, and that's also your call. So totally collaborating rather than confronting. And then lastly, evocation. That means that we recognize and we try to pull out that they have the needed resources in them right now, that they don't need anything to happen, that they can make this change today if they so choose, that those resources are already available within them, and that they have those strengths, right? And so we're capitalizing on their why. And it's one of the reasons why it's super important that we understand their motivation to make that change so we can reflect it back to them. So when we're doing evocation, what we're doing is really enhancing those intrinsic motivators that they already have, their goals, their values, their why for making this change, rather than looking at it from a deficit perspective. Because remember, we're not going to get to giving them skills until they're actually in the action stage. When they're in contemplation, it's just reinforcing the fact that they can do it, that they have the ability to do it, and that they've been successful with other things in the past, right? So in general, what we want to move away from when we're using the spirit of MI with our patients is this. We don't want to wrestle with them. We don't want to be coercing or forcing or persuading, but instead we want to be dancing with them. We want it to feel easy and comfortable. And there might be a couple missteps, but along the way, it really is a collaborative partnership. So that's it. Any questions?